Including targeted therapies that may be more effective and less toxic than traditional chemotherapy. Our approach begins by looking at genes, oftentimes hundreds, that are known to be associated with cancer, using a tool called next-generation sequencing, or NGS, to help find alterations in the patient's DNA that are causing the cancer to grow. Alterations can happen anywhere in the gene, and there are 4 major types. The building blocks of our DNA may be substituted, inserted, deleted, duplicated, misplaced, swapped, or just plain broken. In all of these cases, the cells may end up working differently, causing a tumor to grow. Other tests, such as multi-gene hotspot NGS tests, only look for 1 or 2 types of alterations in predefined parts of cancer genes. Hotspot tests, therefore, may identify common alterations, while overlooking unanticipated but potentially important and actionable ones. By contrast, Foundation Medicine's comprehensive genomic profiling approach broadly analyzes the tumor genome to identify clinically relevant alterations and potentially expands your patient's treatment options. We offer a portfolio of comprehensive genomic profiling services for patients with solid tumors, hematologic malignancies, and sarcomas, including a liquid biopsy service for patients with solid tumors. Our approach analyzes cancer-relevant genes to detect the 4 major classes of alterations specific to an individual's cancer. Some of our services also measure specific genomic signatures, such as tumor mutational burden and microsatellite instability, which can help inform the use of immunotherapies. To find these alterations, Foundation Medicine uses advanced algorithms developed by some of the world's foremost cancer genomics experts and computational biologists. Our approach combines this expertise with our database of cancer genomic insights, one of the world's largest, to continually optimize and improve our algorithms, allowing us to efficiently and accurately discover the unique alterations and genomic signatures in a patient's tumor. We then issue a clear, in-depth report with insights on the patient's genomic profile, as well as associated targeted therapies, immunotherapies, and relevant clinical trials. The end result? Doctors have what they need to make a more fully informed decision, and patients have the assurance that no stone is left unturned in their treatment.
So, good afternoon to all. As always, on behalf of Dr. Fadi Farahat, President of Cancer Research Group and the Arab Medical Association Against Cancer, it's my pleasure to introduce you to our ABC Oncology educational course, which will be about advancing precision medicine in community oncology practice. The activity, as you know all, it's endorsed by AMAC, UICC, and ASCO. At the same time, it's awarded by 2 CMEs. It's my pleasure to introduce our panelists for the first session, who are going to introduce the speakers. We have Dr. Rami Mahfouz. Dr. Rami Mahfouz is Professor of Pathology and Laboratory Medicine at the American University of Beirut, and Dr. Faris Al-Ajje, Associate Professor at Qatar Biomedical Research Institute. So please, Dr. Rami Mahfouz, if you would like.
Dr. Ahmed Awada should take the...
Yeah, Ahmed Awada, okay. Dr. Ahmed, please.
Okay, thank you, Dr. Sami, for this introduction, and thanks to Professor Farhat for inviting me to share this really very important webinar. I think the topic is very timely and very important for every oncologist now working in this field. So the program is really nice. And without any delay, I propose to invite the first speaker. The first speaker is Professor Rami Mahfouz, well known by all of us. He is a professor of pathology at the American University of Beirut. He will introduce the subject in summarizing one of the important tool for molecular oncology, for precision oncology, the molecular tumor board application in practice. Rami, I think it's important to remember the attendee that we could have the translation from English to French during this webinar, and this is really very important for our colleague eventually in Algeria, in Morocco, eventually in Tunisia.
Thank you very much, Professor Awada, for your kind introduction. Thank you very much, Dr. Farhat, for inviting me to be part of this exciting activity as usual. And of course, my thanks to Roche and Foundation Medicine, SciencePro for the introduction and invitation. So navigating the complex molecular data toward the clinical decision in the molecular tumor board setting. This is an extremely important and hot topic today. And as a disclaimer, I also do not have any conflict of interest regarding any personal product or company or trade name all through the presentation. So what we are seeing today is actually a very high in number and building targeted therapies, whether be it by testing or by the presence of the novel biomarkers that we are looking for. So whenever we are testing for biomarkers, we are trying to find the most prognostic, the most diagnostics, and the most important markers that will lead to our engagement in the patient management to the best. So we know about the targeted inhibitors that we have been following through many different techniques that we have utilized. But as well, and as you've heard in the introductory video, we have some few genes that are being targeted as single or small panels of genetic testing related, like for example, if we take lung cancer, EGFR, ARCAD, or ROS1. And also we can have multiple genetic biomarkers that are used in also like general panels where we have more than 5, 10, 20, or 50 genes at the same time. So today, what we are doing is moving and shifting away from these single markers actually to try to get a very broad picture of the whole genome as much as testing is also involved. We can go into hundreds, 200, 300, or 400 genes in general, but the most important is for us to realize that we are no longer looking for target inhibitors as well only, but also we have the cancer immunotherapies in general, MSI, MMR gene defects, mutations for repair, and also the TMB mutation burden, which is extremely important and gaining more momentum in our understanding of immunotherapies and targeting therapies and the general era of precision or targeted medicine. So the amount of information is actually increasing, and it's not only increasing in terms of molecular pathologists in general, it's also increasing for you as physicians, as also our oncologists, our colleagues in surgery. This is very important because the amount of data that is being building is also going to be available to all parties involved in patient care. And even patient advocacy groups are also advocating to have those patients as well being involved in their decision-making in part of their clinic. However, most of our patients come to us and they are already equipped as well with some information. They go and look at the websites and they start looking for these newly available tests, and they start asking us, what is this information of this genetic test about? What is this? What does this mean in correlation to the pathology of the disease? What does this have to do with my CT scan or MRI or PET scan that I got last month? This is important. So the amount of information available for all healthcare providers is increasing, and we should all be working as a team. This is why molecular tumor boards and multidisciplinary in name should always be present. So we'll be there to all of us to be part of that unique team that is going to start performing this interpretation and analysis of data. We will take the pathology in question as well. We'll have the CT scans, MRIs, PET scans, all the molecular information coming in from these fascinating and new comprehensive genomic profiling tests like we have in hand, Foundation 1, for example. And this means that we'll be all discussing into a molecular tumor board all the available treatment options and what is available for our patients in terms of therapies and indication for treatment. So when we take this into consideration, we are talking about many different sides of patient care and patient management. So when we say the molecular biology or the tumor biology by itself, also when we discuss it in terms of pathology, let us remember that we have a very important topic, which is called the tumor heterogeneity. So whenever we take any biopsy from any site of that tumor and look at it under the microscope or just perform testing on that specific part of the tissue, we are limiting our interpretation to that specific piece of information or piece of tissue. So this is why more comprehensive genomic testing today are knocking at the doors of liquid biopsies. And we can do this through a peripheral blood venipuncture and take a much broader three-dimensional, if you want, spatial, temporal, and also genetic diversity related to the tumor itself in a three-dimensional way. So the products released by that tumor are going to be released in circulation, and we're going to collect and do our best to analyze this genetic information and reflecting what's happening at the level of the tissue if we're not able to get another piece of tissue from that same patient. So clinical oncology, genetics and bioinformatics, clinical genetics, because the presence of genetic counselors is of extreme importance at the table of a molecular tumor board when all oncologists, surgeons, physicians as well are discussing the best treatment option for our patient. Thank you very much.
Thank you, Rami, for this introduction and for really emphasizing the importance of molecular tumor board and the component of molecular tumor board. I think without the molecular tumor board, it would be impossible to interpret well the result, and which will be important for clinical practice. The strength of this webinar that there are different aspects. There are theoretical part, but also what is important for clinical practice. And so we have three cases will be discussed by three colleagues, Dr. Fadi Farhat, Dr. Joseph Magdisi, and Dr. Hazem Asi. And we have with us two colleagues will participate to the discussion of this case. Dr. Rami Mahfouz, Professor of Pathology at AUB, and Dr. Faris Al-Ajra, Associate Professor of Qatar Biomedical Research Institute. And without any delay, I propose that Fadi will present the first case in relation to precision. I prefer personally the word molecular oncology. Fadi?
Thank you very much. I would like to know if I can move the slides, Vanessa.
Yes, doctor, you can.
I cannot. Okay. I cannot, so I will tell you next. So we as practitioners are suffering from many obstacles. There's many obstacles when we talk about the precision medicine. There's the cost, there's the problem of late request in some cases while the patient is really in advanced stage. There is mainly the interpretation of the test. And I remember the first test I prescribed, it was a CARIS-1. It was the first in the region. It took me a few minutes to read it, while now if I want to read a test, it takes more than 1 hour to understand what's happening. Nevertheless, we are still not doing a good interpretation. We have a lot of alteration of unknown significance, the choice of drug, and sometimes the accessibility of trials. You know, in Europe, it's easiest to go and to get access for any trial in the European Union or USA, while it's not the case for us. Next, please. So here I will present a case diagnosed in 2003. It was a left breast infiltrating ductal carcinoma, a modified radical mastectomy, axillary lymph node dissection. It's a PT2, N2, M0, and ER/PR positive, HER2 negative. Received chemotherapy, FAC, as usual, and radiotherapy. Then after endocrine therapy for 5 years. Next, please. And then after the patients showed in 2018, 15 years later, large left adnexal mass. She underwent surgery. It shows that it's serous carcinoma of the ovary and invading the endometrium upper third of myometrium, omental biopsy was positive. So it was a huge tumor. And we tried first line cisplatin paclitaxel with no result, second line gemcitabine bev carbo no result, and she progressed, she responded a little but progressed at cycle 5. And so then we went to the genomic testing. Next, please. What's amazing, we received such a picture. Look, about 10 alteration, For somebody who doesn't know what KDR, we understand about the kit, but usually mutation, PDGFR mutation, but here we have PDGFR amplification, PIK3CA amplification, BRAF, KEL, PIK3R1, PRKCOI, TERK, TP53. So a lot of alteration with for us non-clear significance. And when you go and you read, there was no therapies designed for such alteration. Next, please. In this indication, but in other type of tumor, I mean not breast, you can find that we have some medication like sunitinib, imatinib, and others, everolimus, many TKIs, multi-tyrosine kinase inhibitors might fit in other indication for such alteration. Next, please, but not in this type of tumor. And again, we initially didn't knew well what type of alteration. We used to say a mutation for any kind of alteration. Now we see the difference, but in my opinion, it's not clear for all of us that we have alteration as base substitution, insert deletion, indel, or amplification of numbers or rearrangement, etc. Next, please. Next, also showing here. So why we have such different alteration? Is it because of the heterogeneity into the tumor, or the heterogeneity into the different tumors, different organs, as Dr. Mahfouz said, that really that's why we are approaching more and more the liquid biopsy, or for other reasons we have a lot of such alteration. Next, and what to do for us? What should I choose from here? Which one is the dominant? It might be the KIT amplification. We do not understand as a clinician what can be the driver alteration, and even we do not know if any of these alteration has an impact on the pathogenesis of the tumor, or on the progression of the tumor, or the oncogenicity, or in the aggressivity. We do not understand this in this alteration. Next, please. So just to tell this case, and to say that finally genetic, we need more experience, more knowledge. We need the competence in order to go and to see, to understand and to treat such cases with a lot of alteration. Thank you very much.
Thank you, Fadi. I think we will start to discuss this case. I think Rami and Fadi, there are several questions in relation to this case. One of the question is, do we have several, let's say, gene abnormalities we don't know exactly how to deal with? That one question. And I will add two other questions from my side. Should we test early in the metastatic setting or late? And third, if we have a mutation or gene abnormality, how we can know the importance in the carcinogenesis process, and before to jump to drugs, the clinical trial, and so on. Faris or Rami?
Thank you, Dr. Awada. If Dr. Farhat also allows me to share my own slide, that I would like to add a few information related to the discussion. Can I have?
Please, Vanessa, can you share? Just to tell you that we are more than 100 attendees. Thank you for the audience.
Fadi, I cannot see the question from the attendees. Please check this because I don't know why I cannot see this.
I will check it.
Okay, so if you allow me a few minutes to add to the excellent slides by Dr. Farhat. So I'm not going to add, of course, anything in comments to the, I hope you can see my screen. So I'm going to analyze the genomic findings per se, as we have seen by Professor Farhat. So the KDR kit and the PDGFR alpha actually by themselves are all under what we call the 4q12 amplification segment. This is also something which is very well known on chromosome number 4. The KDR, by the way, is also called the VEGFR2. Which may or may not respond to anti-VEGFR therapy. We don't have information that much about it in more clinical trials. So on chromosome number 4, over like 900,000 bases, we have PDGFR alpha and the KDR surrounding the KIT gene on that small segment of the 4q12. Q is for the long arm of chromosome 12. And by default for 4q12, the distribution is actually as such. So you see in all the cases, as you can see it from the TCGA website, this is Dr. Farhat's case. It has a breast and also it has the ovarian. So if you see it here, this is where in the case of breast invasive IDC and intraductal invasive ductal carcinoma and the ovarian serous carcinoma. But the K4Q12 amplification is actually much more prominent in many other solid tumors. As Dr. Farhat mentioned, we can see it in other tumors, and it's known to be amplified and over-amplified in like head and neck, in the trachea, adenocystic adenocarcinomas, etc. So mainly in the head and neck, but not in the other sites as described. So for 4Q12, there is an important study in 2020 that categorized 133 almost 1,000 cases and mentioned that the recurrent 4q12 amplification was identified across many tumor types with specific enrichment in sarcomas as a whole, several sarcoma types, CNS neoplasm, and several cancers that arise in multiple anatomic sites. So there was a need and call for larger advocative and collaborative efforts, including the NCI match and ASCO TAPUR trials, that they may be the optimal forum to explore this amplification, knowing that the 4q12 is not currently included as a drug match. But the 4q12 amplification can also be characterized as an oncogenic contributor, either in conjunction with other oncogenic drivers, which is very important to identify the driver mutations when we seek initial treatment, as suggested by lungs adenocarcinoma therapies, for example, or trials. And ongoing clinical trials with diverse TKIs may further define the extent of 4q12 amplification targetability and should be linked to an assessment of whether the TKI therapy with a chemotherapy backbone may maximize patient benefit. Now, regarding PIK3CA amplification, and you know the PIK3CA is on chromosome number 3, before the discovery of the mutations, actually gene amplification of PIK3 was reported in various malignancies, including approximately 10% of breast cancers, which is also present here in our case. And it also associates with resistance to chemotherapy in ovarian cancer patients. So this information produced by the Foundation Medicine or by the this comprehensive genomic profile test couldn't have been assessed if we were able to perform only simple targeted testing for regular gene panels. So the BRAF in this case, and the BRAF gene is on chromosome number 7, the amplification is the BRAF by itself gene is altered in 2.24% of ovarian cancers. Patients with BRAF amplification present in 0.2% of all ovarian carcinoma patients. So far, these findings are going with the breast and the ovarian history for the patient. And the most frequent genetic aberrations found in low-grade serous ovarian cancer and the serous borderline tumors, as well as mucinous cancers, are the mutations in BRAF and KRAS, and here it's again the regular V600E mutation. Regarding the KAL amplification, the KAL is on chromosome number 7. We do not have much data, but there are studies implicating that it might be involved in resistance, and there is really no direct relevance to the case, which is something that we usually find. So when we get into these very high number of genetic testing, we might start getting mutations and abnormalities that we don't know what to do with them. And also for PIK3R1, which is not the regular PIK3CA mutations on chromosome number 5, Actually, Professor Farhat himself has described this same mutation in one patient with ovarian cancer, and that was published in the case report of Oncology in 2020. And the conclusion was that this alteration, actually it was new, it has not been previously reported in ovarian cancer, and could plausibly enhance the PIK3CA amplification effect in strengthening the ACT-mTOR, as you know, pathway activity, and which lead to tumorigenesis, so going into the mutation driver effects. And there were no therapeutic interventions at that time. For the PRKC1 on chromosome 3, it's also a 3q26 locus. It is a key feature actually of high-grade serous ovarian carcinomas, and it promotes immune suppression in ovarian cancer cases. A very interesting study in 2020 by Professor Rahmani that there might be an aptamer-based targeted therapy in ovarian cancer that's showing promise. It's like a silencing of this gene at the level, so therefore inhibit the PRKC1 amplification effect. So that would also be available for the oncologist when they consider treatment. TERK amplification, TERK on chromosome number 3. This amplification is documented in 0.44% of AACR gene cases with squamous cell carcinoma of the lung, high-grade ovarian serous adenocarcinoma, anal squamous cell carcinoma, and the breast invasive ductal carcinoma and esophageal adenocarcinoma having the greatest prevalence indeed. So it's also interesting that it's in the same region as the PRKC1 gene, and it might be also a very important target, but in non-small cell lung cancer as documented in 2003. TP53 is well known on chromosome 17, and this specific mutation, actually the R273C, is present in 1.27% of AACR gene cases with colon adenocarcinoma, lung adenocarcinoma, breast invasive adenocarcinoma, ductal carcinoma, anaplastic astrocytoma, and colorectal adenocarcinoma having the greatest prevalence. And this induces, again, a function that induces HER2 overexpression in cancer cells. So, as Professor Farhat has mentioned, we have several different options, and the question would be, what's next in therapy? Thank you.
Okay, thank you, Rami. Okay, Fadi, you have all this explanation from Dr. Rami. What will be your decision eventually for clinical practice?
Yes, indeed, I had to choose, knowing that I'm not sure which one is the driver mutation. Since the PIK3CA, it was amplification, and the report of success were with the mutation, I couldn't use alpelisib. So the KIT amplification also was there, and I thought it's the easiest one, also knowing that it's not a mutation, it's amplification. That's again the problem when you have some indirect signs you do not know. I will say it differently. Now we know in the new era that the KRAS mutation is independent from the PIK3CA, is independent from the PDL1, so you can target it, but we do not know when you have a c-KIT or PIK3CA, which one is, if there's any correlation. We know that if you give anti-RAS with the new drug, sorafenib, I forgot the name, you do not need to check on the PDL1 or PIK3CA and others. But in my patient, I didn't know, so I went to imatinib simply, saying that c-KIT might be helpful. The c-KIT target. That's what I did.
And what was the result? Do you have?
I had a symptomatic treatment, but symptomatic result. There was no really objective response. But as always I say, for my colleagues, when you do the genomic profiling, you do not expect to cure the patients. It's like when you give palliative chemotherapy. It gives you the way to choose the best treatment for a survival prolongation or symptomatic treatment. Remember that at the beginning, we had a lot of chemotherapy that were approved simply because they improved quality of life, symptomatic, like Novantron in prostate cancer and others, or Tarceva in pancreatic cancer. So I said to the family, we might get a benefit from this drug, and symptomatically the patient improved for a while.
Okay, thanks, Fadi, for this really nice case. I think from my side, my understanding from this case that really we need in our molecular tumor board people like Dr. Rami to dissect these really gene abnormalities. And from his presentation, I understood why this patient didn't respond well to chemotherapy. At least there are several reasons from your review of the literature about this gene abnormalities. Of course, from the therapeutic point of view, that is much more complex because not always the drugs are available. We don't know exactly if what we have in our hand is driver mutation or gene abnormality. So there are a lot of questions around that. Without further delay, I propose to move on to the case number 2, and I invite in my let's say agenda here Dr. Al-Maqdisi to present the second case. But I saw Joseph. No, Hazim.
Thank you, Ahmad. Thank you, Fadi, again. يعطيك العافية. And it's always very hard to present, especially when we talk about molecular tumor board, to present after Dr. Rami Mahfouz. So can I move it myself? Okay, sorry. So I choose really a simple case, but it's something that we see routinely, and it might answer the questions that Dr. Awada asked. When is the timing to really order those type of very expensive tests? So I'm going to talk about a male, he's 73. He came here for a second opinion concerning a recurrent retroperitoneal dedifferentiated liposarcoma. He has no family history of malignancy, and he has only a high blood pressure as comorbidity. So history goes back to 2017 when he presented with a 20 centimeter retroperitoneal mass upon an incidental CD finding. He underwent surgical resection, and pathology was consistent with dedifferentiated liposarcoma with high mitotic rate and a high grade with a positive margins. In October 2018, he had a recurrent disease with 3 different recurrences noted: retrohepatic at level of kidney and at level of distal ureter, each about 6 to 7 centimeters. All images were done outside the UBMC, and really we didn't have access to the slides. So at that time, olaratumab was approved by the FDA in combination with intracycline as first-line treatment based on a phase 2 trial. So patient received 4 cycles, and he developed cardiac toxicity with drop in his ejection fraction to 45%. So in April 2019, so the epirubicin and olaratumab discontinued. In April 2019, MRI of pelvis done and showed a further increase in all the size of the masses. So he came to, a biopsy was done at that time and confirmed dedifferentiated liposarcoma. MSI was done at that time, and it was retained, which is expected in sarcoma, in soft tissue sarcoma. So in May 2019, we saw the patient. We discussed at our multidisciplinary tumor board. Images were reviewed by the surgeon. Surgery wasn't an option. It's usually our first option when it's feasible. Chemotherapy usually is not associated with a significant clinical benefit. It's usually correlated with a low objective response rate and a poor OS. It's known to be a chemo resistant. So we decided to proceed with NGS, and we choose Foundation 1 heme at that time. So here we see the results. MSI, TMB, MSI was stable. Tumor mutation burden was low as expected in soft tissue sarcoma. It's not that common to see MSI. So BRCA2 loss oxygen 2127. It was the only genomic findings, which makes things easier on us. So the therapy with clinical benefit was a PARP inhibitor, niraparib, olaparib, bucaparib, and talazoparib. At that time, none of those drugs were available in Lebanon. We are talking about June 2019. Olaparib just launched last month in Lebanon, and the talazoparib maybe a year ago. So when we talk about BRCA2 less exon 21, 27, we see extensive, so that alteration is present in extensive type of solid tumors, which usually indicates that inactivation of BRCA2 may confer sensitivity to PARP inhibitors, as we know. And the clinical response to PARP inhibitors has been reported for patients with either germline or somatic BRCA2 mutation. BRCA2 mutation and deletion is very rare, but it has been reported in 1% of soft tissue sarcoma and in 3% in the TCGA database. In one of the studies, 112 soft tissue sarcoma, the positive expression of BRCA2 correlate with aggressive tumors as well as shorter disease-specific survival and event-free survival. It means more aggressive disease. So the two drugs that we have was olaparib and talazoparib. We have some evidence, some phase 1b study that olaparib in the soft tissue sarcoma in the presence of BRCA2 mutation can achieve some kind of partial response or stable disease in liposarcoma. Also, we have data for a different type of tumor, mainly pediatric tumors, that talazoparib can has some kind of objective response rate around 12% in BRCA2 alteration tumors. Back to our study. So we recommended olaparib. Patient got it from Europe. After a few months, talazoparib was accessible through a compassionate use. So we started in June 2019. 6 months later, we moved to talazoparib. Olaparib was very well tolerated. Talazoparib was associated with anemia, requiring monthly blood transfusion. So we had to reduce the dose to 0.5 milligram, which was really the maximum tolerated dose for the patient. And we have doing CT scan. It shows really at the beginning an objective response rate, maybe around less than 25% objective response rate, less than 25% reduction in size of the tumor at different sites. However, it has been stable, and the patient is at a professor at university, and for the last 2 years, he continued to work really without any interruption. Almost, we can say we achieved a stable disease for now 2 years, and he continues to work completely asymptomatic. He used to have a lot of pain initially. That's my case. Thank you very much again.
Thank you, Dr. Hazem, for this case, and a really interesting case. My understanding that Dr. Rami has some slide in relation to this case.
Dr. Ahmed, is there any question, any comment from Dr. Faris Al-Ajji, since he's also with us?
Dr. Faris?
Yeah, thank you. So I was just going to comment about case number 2 and also case number 1 from Dr. Fadi. So for case number 1, it looked like this is a familial history, like having breast and ovarian cancer. It's a bit odd. I'm surprised they would not find any BRCA1 or BRCA2 mutations, or were they not on the panel. And the next question for case 2, since it was BRCA2, there is some evidence that cisplatin in combination with PARP inhibitors might have worked more efficiently, maybe for the this case. The issue now, from what all the questions, and of course I will not cover it as deep as Dr. Rami. It was quite impressive how it covered the previous case. The issue is that what do you do when the indication is for another cancer and there are no clinical trials? And I don't think anyone has the answer for this. It's a problem to go off-label, and generally you have to go through a really expert, geneticist along with molecular pathology to make you best, how can I say, not choice. Sometimes it's a bet, to be honest. It's very confusing, and the literature is not sufficient enough in these certain type of cases you're presenting. This one with the BRCA2 is a bit easier, but I mean, I'm not a clinician, but I think cisplatin may have been considered in combination with PARP inhibitors for you know, a BRCA2 patient. I might be wrong about this, of course.
Dr. Faris, I have also another question for you, because I saw here the total mutational burden is 4. What is the threshold now recognized, you know, in order to give immunotherapy to our patient?
So it's 10 mutations per megabase of protein, DNA, I mean, I'm sorry, which is actually brings me back to from Dr. Fadi's case. It looked like high mutational activities in that case. It's mainly amplifications. So that was another question about doing anti-PD-L1 or TMB, because maybe immunotherapy could have been an option for that case. Because the PI3K mutation, for example, if it was only breast cancer, we know now that for refractory ER-positive breast cancer, PI3 in the metastatic setting, particularly PI3K mutation for breast cancer works. I'm not sure how that would have worked for the ovarian. And I'm really suspicious about this whole breast ovarian, you know, manifestation. It looked like some sort of related to some DNA damage repair, CHEK2 maybe, or BRCA1, BRCA2 more likely. Yeah, so I think immunotherapy may have been an option, and the Foundation 1 panel now will allow TMB, and I wonder if that could have told you anything, Dr. Fadi.
Okay, thank you. Dr. Rami? I think you are in mute.
Okay, sorry. Yeah. Can you hear me? Okay.
Yes.
Okay, so the findings were MSI stable, tumor mutation burden of 4, and the BRCA2 loss of exon, huge error between 21 and 27. So just to brief you pathologically before I go into the genomic between the well-differentiated and the de-differentiated liposarcomas, and why it's important just to highlight on them. The well-differentiated represents 40 to 45% of all diagnoses of liposarcomas, and it's classified as a low grade. It's rarely metastatic and has a low recurrence rate of 10%, occurring most often in the retroperitoneum and limbs. The D-differentiated represents progression from the low to high grade non-lipogenic morphology within a well-differentiated. And the D-differentiated is more aggressive and exhibits an increased rapidity of disease in contrast to the well-differentiated, which is also the takeoff of a pathologist here, adding this information and in classification, of course, whereby to expect worse prognosis or behavior of disease, which is good information for the oncologist, as you know. There's a metastatic rate of 10 to...
Rami, sorry, there is a translation ongoing. I am not sure that they can follow you. So please, if you can...
Slow down?
Yes, slow down.
Okay, just for the sake of time. Okay. So there's a metastatic rate of 10 to 20% and overall mortality of 50 to 75%. So in respect to tumor site, retroperitoneal tumors appear to have a worse prognosis. And histologically, the D-differentiated consists of a well-differentiated with a non-lipogenic component, either high-grade, most often resembling malignant fibrous histiocytoma, or low-grade resembling fibromatosis or low-grade myxofibrosarcoma, which is very important because most of the assays today are really taking these changes in histology into account. And the genomic findings are really taking us to sub-classification of these sarcomas in general. So the presence of transition from the well-differentiated to differentiated is used to differentiate between these and other lesions as well. So this is important because if you take it at the level of a karyotype or genomic testing, when we say a well-differentiated or de-differentiated, there's a typical supernumerary ring or giant rod chromosomes that we see at the level of a genetic defects, and we see segments amplifiable within the 12q13-15 region. And the beauty of comprehensive genomic analysis is actually to encompass many other alternative testing than the regular or conventional ones. In addition to immunohistochemistry, for example, as Dr. Faris has just mentioned, for PD-L1, we can use FISH or comparative genomic hybridization as an add-on to try to detect more abnormalities. So in these specific cases of liposarcomas, the oncogenic drivers are actually an MDM2, CDK4, HMGA2, TSPN 31, OS1, OS9, CHOP, and GLI1. So, and the most compelling evidence actually demonstrates that they do have an oncogenic role, specifically the MMD2, the CDK4, the HMGA, and the TSPAN 31. So these are four more very important, and they are documented in the findings. So back to Dr. Asi's case, the microsatellite stability is actually going very well with the soft tissue sarcomas because the MSI is not high. The TMB as well is low, which also goes with most of these cases of soft tissue sarcomas. And the interesting finding was in BRCA2. However, in this signature for liposarcoma, this new finding is not the usual one. So it's not present in liposarcomas in general. However, it doesn't mean that we should not, or the patient may not be taking this into benefit if we can do it as a compassionate use. So as I said, when we are digging into the various subtypes of sarcomas, we do have a battery of genes, and what is important actually is when you select the genomic testing in question, always ask for what is important. So if you're looking for NTRK fusions, for example, it's not good to go into a DNA test analysis only looking for NTRK mutations because you're after the fusions, which means that you need an RNA-based test that will also support you. So it's very important when you're looking among the different tests. So by using the foundation as well, you can detect these translocations and fusions. So the BRCA2 literature mentions that in this loss of 21 to 27 exons, there is documented sensitivity to trabectedin. And also when we use niraparib or lorazepam or talazoparib, these are important for both somatic and germline mutations. So in light of the age of the patient and no family history, I would also stop, like as Professor Ashri has also mentioned, that as we question if there is a BRCA1, BRCA2, or TP53 inheritance in a germline pattern in those families, but which is not applicable in this case. And as Dr. Asi mentioned, the presence is important because this has been documented in the PCGA database, and it confers to aggressivity of the disease as well. Thank you very much.
Okay, thank you, Dr. Rami. Thank you. I have one question in relation to clinical practice. Do you think this is a question for my colleague clinician? Platinum compound could be of interest in this case?
Questions? Ahmed, سؤال question for me?
Oh, yes, because yes. There could be an option in this patient.
It could be like as Rami mentioned, in liposarcoma, the only drugs that shows really some kind of clinical response, objective response, are Yondelis, trabectedin. It's the only one. We have so far, we don't have any data with cisplatin. However, we can extrapolate from the breast cancer data that we can use in sarcoma, but in soft tissue sarcoma, cisplatin is not a drug that we routinely use. In soft tissue sarcoma.
But that is the aim of the genomic profiling, to use
about yes. But not about the chemotherapy. Like it's data, it's more about target therapy, Fadi. About chemotherapy and NGS, really, we don't have like evidence enough to support using cisplatin in this case.
This is
liposarcoma is a very chemo-resistant tumor.
If you allow me, Dr. Awada, this is the problem of clinician. We are not yet used to see that the genomic analysis is leading us to understand the interaction between different pathways due to different alteration. So when you talk about a BRCA mutation, probably in breast cancer, in ovarian cancer, it's leading to a platinum sensitivity. Now, can we extrapolate on other sarcoma? I don't know, but still we have to use it as an option, as we do, for example, for HER2. You will tell me it's more for target therapy. Yes, it's true. When we find a targetable alteration, yes, it's clear. But personally, I will keep platinum, salt cisplatinum as an option for this case. Yes, you have trabectedin, but also cisplatinum might be used, and it should be used to learn from that. If you will have the chance to use it, it will be a teaching lesson for all of us.
Yes, I agree. I agree, as long as we keep it for a later stage of treatment.
Okay.
Yeah,
So,
I think that could be an option. You know, in these cases, I think it's important to sometimes think out of the box. I am thinking about platinum, but also in terms of therapeutic strategy, could be probably to start with trabectedin, for example, and when the patient is stabilized, to continue as maintenance with PARP inhibitor, or started with platinum when we have stable disease to maintain with PARP inhibitor. But I am saying this without any support to that, but I am sure that will not have the support. So we can learn from case to case, of course. This kind of situation, we need to sometimes think out of the box. Okay, in order to stay on time, I think it's time now to invite our friend, Dr. Magdisi Joseph, to present the third case.
Merci, Ahmad. Good evening for everybody. And miss you all. It was a long time. I will present a case. Next slide. So the aim of presentation of this case to define the best time to do foundation test and how we miss many important information with our classical test. Is a young patient, 47-year-old male, who complains of back pain for a few weeks before the presentation. When he did the MRI showing a bone lesion in the lumbar. So we did the biopsy in the bone showing a moderately differentiated adenocarcinoma from a lung origin. We do the molecular profile, the classical one at Lebanon, showed the EGFR mutation at the exon 9 deletion. It was in November 2017, so we started first generation anti-EGFR, gefitinib Iressa, with a good clinical response, decrease of pain, and radiologic response, decrease in the size of the lung tumor. Until May 2019, he started to complain of dyspnea. We did a CT scan of the chest showing a progression in the tumor in the lung. So at this time, I did a biopsy, a new biopsy, to test the mutation for T790M. So I sent the test in Lebanon, not on NGS, on a classical, on PCR, I think. Can we move? Next slide. So this pathology, adenocarcinoma, moderately differentiated. Next. This is the result of T790M on the tissue by PCR analysis. It was negative. Next. And also in plasma, also it was negative by BUS. Next, please. So when it was negative, I started the chemotherapy. We know from retrospective data and from experts like Ahmad, like you, that giving immunotherapy in patients with EGFR mutation, they show no answer, no response. So we started chemotherapy. Cisplatin Alimta received 2 cycles with no response at all. Then he received Keytruda, a third line, between July 2019 until January 2020. At this time, the CT scan showed a further progression in the lung tumor with more extensive infiltrates, with the clinical impact and dyspnea. At that time, I decided to do Foundation 1 CDX and sent for results, then came back with a positive mutation of EGR T790M, exon 19 deletion. So we started a treatment with osimertinib, Tagrisso, for 1 year until February 2021. When we started to complain of dyspnea because of increase of infiltrates in the lung, and at first he responded to antibiotics, then he didn't respond, further increase in infiltrates, and he passed away 1 month later. So if we did this test at the beginning, at the first progression, maybe we save not only money, but we save also clinical symptoms. The quality of life will be better. I want to discuss about this issue.
Thank you, Joseph, for this important case. I think that's once again the question about Dr. Faris about the timing when to do the test. Here is probably clear at the beginning, and which kind of test to do in order not to miss something really important, because this patient at the end benefit one more year.
Exactly. And I think that's a very most important question here, is that, I would call it, and I will touch on this in my presentation, it's ad hoc treatment decisions when you have progression, while all of this should have been done at the time of first diagnosis, I would say. We have to also think that the tumor does evolve over time. So some mutations might come up later, so we cannot forget that, and that's where liquid biopsies might be helpful for monitoring. However, I would have said for this case, yes, the testing should have been done earlier, and this is an argument I will also be making in my presentation, that saving costs at the beginning, you'll end up paying more for the healthcare and also the patient, years out of their life at the end, because you're just doing this ad hoc decision making based on progressions. So what you pay at the beginning might save you a lot of time and money, and of course the patient life, if you have done it right from the beginning. I would have said that. And in terms of the panels, I think the comprehensive genomic panels, not whole genome sequencing, we might get lost in interpreting this, but at least the Foundation 1 panel or the tumor site oncology panel from Illumina, they will give you all of this information right from the beginning, including TMB, including MSI. This is an EGFR mutant, so PD-L1 expression is not really generally high in those tumors. However, that particular first mutation you saw, the mutation in, what was it, the mutation? Sorry, the first one you observed. I forgot the name of it. I'm really sorry. Yeah, exon 19 EGFR.
Exon 19.
Exon 19. Those cases sometimes have high PD-L1. It can vary from like 5%, which is meaningless maybe, up to maybe 40%. So that particular mutation is slightly different than others. PD-L1 is usually high in EGFR wild types. But to answer your question, the testing should have been done earlier, in my opinion, not for this case only, for every case. The more information you have at the time of first diagnosis, it enables you as the MDT and with the molecular pathology interpretation that you have planning decided prospectively for the patient. You have options and you can think about them from the beginning, and in case they don't respond to treatment X, you can go for treatment Y. This is more for the MDT to decide, but from a scientific point of view and from understanding the clinical profiling of these tumors, that would be my answer.
Okay, thank you, Dr. Faris. I don't know if Dr. Rami has something to add.
I had one slide to show, but that's fine if I can just say it if you want. Actually, what Dr. Makdisi has done is perfect in terms of following up of the patient with the comprehensive genomic testing. But if you look at the dates in May 2019 versus the January 2020, and at this time there was a request to perform the on a liquid biopsy, and the EGFR turned out to be negative 4790M. Now, just my advice, of course, the comprehensive genomic profiling is going to give you the full picture, and if you also get more information about other parameters that we have at the same time, it would be great. But by regular real-time PCR, even when we talk about liquid biopsy in general, we have to be careful about a very important issue, which is the handling of the specimen itself. The short life of the DNA in circulating tumor DNA in the periphery is within a maximum of 2 hours. So if you're sending that specimen on a Friday and you're expecting to be sitting at room temperature in a certain lab or even an international lab using only real-time PCR, it would be like something that would give you a false negative to start with. And the sensitivity is acceptable for real-time PCR still, and which is also documented in the latest studies for osimertinib as first line. This is why I also, if that patient could not afford comprehensive genomic profiling at that time, maybe consider repeat testing through a 14 days lapse if you had a time at the time of the first negative, or just simply repeat it or make sure that the specimen is received by a lab at appropriate timing for their own operation, or at least for preservation to extract the DNA. Now, I fully agree with Dr. Faris that the information that is going to be provided by the comprehensive genomic profiling is also important. And yes, I would agree with Professor Magdisi as well that testing using this, though expensive technology at an earlier stage, is something very important and beneficial for our patients.
Okay, thank you.
Thank you.
Dr. Rami. I have a question here before to finish with this case. Now, if the patient, let's say, progress on osimertinib, let's say still in good conditions, this patient, do you think that's to go once again to test this patient genomically to see at least what is the reason why this patient resists to osimertinib? Because we are starting to see some new drugs in patient resistant to osimertinib, or some combination of drug, for example, at the last ASCO. Probably liquid biopsy here will be, let's say, will facilitate the thing. And understanding the resistance is something important also for the patient.
But clinically, but from Ahmed, there was no progression in the size of the tumor. The progression only in the infiltrates in the lung. So we are not sure that there was a progression on osimertinib.
Okay, but in case of, fine. Fadi, is there any question from the attendees? Because I am not seeing this.
No, Ahmed, no, I don't see any question and answer, no open questions.
Perfect. I think thanks a lot for really Dr. Farhat, Dr. Magdisi, and Dr. Asi for these three important cases, and for Dr. Rami and Dr. Faris to comment these important clinical cases. I think with that, we finished the first part of the webinar on time, and we are ready to start the second part. We'll move directly, Fadi, without any rest period.
Yeah, yes, please.
Okay, so we'll move on to the second part of this webinar, and we have two presentations. The first one will be done by Dr. Fadi Farhat about tumor profiling perspective.
Vanessa, can you start, please, the presentation?
For the panel discussion here, we have with us Dr. Joseph Kattan and Dr. Radia Mina.
Precision medicine, the second module, I will be talking about the tumor profiling from a daily practice perspective. The agenda, I will approach the meaning of precision medicine from my point of view. I will talk about the advantages of complete profiling. I will talk, in my opinion, who might benefit from this profiling. We will have some cases and with a final message. So what's precision medicine? Precision medicine is a phrase that is often used to describe how the genetic information about a person's disease, about a specific person's disease, is being used to diagnose or treat the disease. So how the genetic abnormalities can lead to the diagnosis or to the treatment. And we know very well that cancer is a disease of the genome. So if we can understand the genetic changes that are in this specific cancer and these cells of cancer that leads to the development of such a tumor, we might give more effective treatment strategy for this specific patient. And this treatment will be tailored to the genetic profile of the patients. And we know very well that there is a percentage of failure of treatment in different indications. Here you can see on the first row the antidepressant failure, the asthma drug failure, the diabetes, and others. But we know that in cancer probably it's the highest number of failure for such treatments, for the treatments. So how tumor profiling can contribute to the precision medicine? Profiling the molecular alterations in a specific patient's tumor can identify the changes that correlate with likely response or resistance. So again, we are repeating that in order to get a response, it's better to understand the molecular alteration, which will be leading to the precision medicine. So the profiling, genomic profiling, will help us in that. And this type of genomic profiling can lead to more precise treatment, replacing the historical one-size-fits-all approaches. So nowadays, one size doesn't fit all. Now to the second part, the advantages of the complete profiling. So why complete tumor profiling is advantageous? Genetic information is passed from one cell to another in the form of DNA. DNA will encode the messenger RNA, and the messenger RNA is then transcribed into protein. So the main test to detect gene alteration in cancer is in three major parts. It might be the DNA analyzed, or mRNA expression, or the protein expression. And the result from this analysis, used with different types of analysis, have different implications. We know very well the EGFR mutation has a great predictive significance, while the EGFR amplification or the EGFR mRNA detection doesn't have the same indication. We know also that in the HER2 amplification, there's a predictive value for the anti-HER treatment, while the HER2 mutation does not have the same implication in the treatment. For whom complete tumor profiling is important? Rare cancer, limited options, sarcomas, gliomas, not tumor. Aggressive cancer with no standard of option or few standards of options, small cell lung cancer, mesothelioma. Also difficult tumors to treat, like ovarian, triple negative, thyroid, carcinoma of unknown primary. All these patients can benefit from the tumor profiling. And we all had in our practice some tumors that are usually sensitive to the treatment, but are unusually refractory in this specific patient, this specific case, like hormone-sensitive breast cancer resistant to all types of hormone, or EGFR mutated lung cancer resistant to all types of treatment. So we might find in this case some unusual alterations. And this multi-platform tumor profiling might help us in understanding and providing a rationale to our second line or third line or later treatment, might help identify therapies which usually are not considered, like anti-HER2 in colon or in lung cancer, or anti-PIK3CA in ovarian cancer or others, or might show us why the treatment is failing and which treatment to avoid. And some clinical cases. These are some of our publications. NGS and IHC profiling showing in a case of endometrial carcinoma a PDN1 positivity, and this is a case from 2015. At this time, it was not standard of care, the immunotherapy in such cases. The patients got a great benefit from anti-PD-1 treatment. Another case of triple negative breast cancer where two alterations were found, a PIK3CA mutation and a Richter amplification. So the Richter amplification showed why this tumor was resistant to all type of chemotherapy, and it shows usually the aggressivity and the poor prognosis. And the PIK3CA mutation gave us an option to use an inhibitor of the mTOR PI3K pathway, and at this time we haven't the PIK3, so we used the everolimus, and we had some symptomatic benefit and prolongation of survival. Another example of an ovarian cancer where the PTEN was lost, so we thought that CDK4/6 inhibitors might be an option, but the retinoblastoma 1 mutation was here the reason of resistance in this aggressive case. And here a case of a first described PIK3R1L44 9S mutation in ovarian cancer case, and this genomic alteration, which is not usually reported, might be the reason of this tumorigenesis aggressive in such a tumor. And a cohort of patients were analyzed. Will not go into the details of the results, but here just to show that breast cancer was in 17% of cases analyzed. We understand it's a very frequent tumor, so probably these cases are the resistant one. Ovarian cancer, lung and colon, a non-primary pancreas. So if you take the percentage of these rare tumor, kidney, endometrium, pancreas, and ovarian and CAP, we understand very well why it was used, this genomic profiling, because these tumors are rare. With that, I will go to the final message. Understanding the genetic changes will lead to a more effective treatment strategies, and this treatment will be better tailored to the genetic profile of this specific case. And the profiling of the molecular alteration, what type is it, mutation or other, will lead to a change in the treatment, and will lead to understand the resistance, and will lead to find more responsiveness if we have a targetable lesion, targetable alteration, sorry. And finally, decoding the cancer will need more than the DNA sequencing. Remember, RNA is important, and the protein immunohistochemistry should be used. And with that, I thank you very much, and I will give the floor to the panelists. Thank you very much.
Thank you a lot, Dr. Fadi, really for dissecting this is not a new concept, it's a really important concept in oncology, which is precision oncology, molecular oncology, personalized oncology. It's really important. You mentioned well the importance to do all this genomic dissection because we could offer to the patient some therapeutic possibility, but I think we can add to that. We understand probably the biology, more the biology of the tumor of the patient in addition to the clinical characteristics. Okay, any comment from my colleague from the panel, Dr. Joseph, Dr. Wahid, Wadih?
Sorry, Dr. Ahmed, if we can keep the discussion to the end
To
of
the end?
presentation,
Okay.
please. Yes.
Okay, let's move now. It's my pleasure to introduce Dr. David Desemir Frappard, Director of Molecular Science at Caris. He will speak about a really important topic and artificial intelligence and precision oncology.
Thank you very much for the introduction. Thank you very much, Dr. Farhad, for inviting me to this exciting session, educational session, and molecular tumor board. 3 cases reviewed that were very interesting. I would need to share my screen to show you my slide deck. So if I may. Okay.
Perfect.
Okay. Are you able to hear me? Are you able to see my slides?
Yes.
Thank you very much. So the title of my topic today is going to be clinically driven artificial intelligence in precision oncology. And precision oncology has been really well defined a few minutes ago by Dr. Farhad. I'm going to bring yet another level of, let's say, complexity, but yet informative artificial intelligence in the clinical management of patients. So I'm a Director of Molecular Science Liaison at Caris Life Sciences. I work in the US. I'm currently in Barcelona helping the international team based in Switzerland. Just really quick about our company. So we have several offices in Dallas and Denver. The lab processing the tissues that you sent us is in Phoenix, in Arizona. And like I mentioned, we have an international team in Basel. So this has nicely been described by Dr. Mahmoud, where the precision oncology is moving from a single gene test to a DNA cancer panel, and recently covered by Dr. Farhad that a multi-omics testing approach is clearly needed to really understand the tumor biology and to improve the chances of having a better clinical management. So for instance, Foundation Medicine sits here with a finite number of genes. We're proposing to do a full analysis of 22,000 genes at the DNA, RNA level, and also a full panel of IHCs for protein. And since our CSO is a mathematician, he loves algorithms, and I'll tell you 2 examples where artificial intelligence can help you manage your cancer patients. So just to familiarize everybody here in terms of what tumor profiling or gene sequencing means. So the tissue is sent to a tumor profiling company, in this case, Caris, in the form of a formalin fixed paraffin embedded block. And there's a heavy biomarker testing done, and also a lot of bioinformatics involved, as you can imagine. And that leads to a report that you receive in your inbox, in your email, or by fax. And and the physician can review the report. And some of the physicians can get lost in so much information, as Dr. Farhad has alluded to. But then is where the science liaisons at these companies are helping you, because we provide scientific and clinical support, like myself. So just before doing sequencing at Caris, and this is a big differentiator for us, we do microdissection. So basically, we try to enrich for the tumor content on the tissue that you sent us. So basically, the slides are examined, and areas containing tumor cells are circled by a pathologist, and a pathology assistant extracts the tumor tissue from the marked areas. So that is critically important for limited tissue cases. For instance, an FNA or an EBOS, in pancreatic cancer or lung, where the tissue is very scarce. And by doing this, we clearly enrich for tumor tissue, and that helps us detect the point, any mutation actually that we can identify. So at Caris, we have a very comprehensive tumor profiling platform depicted here. So at the DNA, we do whole exome sequencing. We cover 22,000 genes, and we focus our attention on close to 720 clinically relevant genes at 1,000x of coverage. This is a very good coverage for an accurate variant calling. Of course, if there are permutations, insertions, deletions, and copy number alterations, we're going to detect it. We also report genomic signatures. I'm going to talk about this in a little bit, but TMB, MSI, and LOH. I will show you the importance of RNA sequencing, and we do whole transcriptomic sequencing, also 22,000 genes, 60 million reads, which basically means 62,000 transcripts analyzed at 1,000x coverage. If there is a fusion, we're going to detect it. And recently, we have genomic signatures at the RNA level regarding HLA. It's not terribly interesting in the clinical management, but HLA and some physicians have asked us to add this because it can help them include or enroll patients in specific clinical trials. In terms of protein, we have a very comprehensive 15 clinically relevant IHCs, of course, all the three PD-L1 antibodies, as well as the MMR proteins. So why doing RNA sequencing? And this is a study from Benayed et al. From Memorial Sloan Kettering. RNA-based analysis identifies more fusions than DNA-based analysis. I'm going to cover this in the next slide, but you'll see the importance of doing RNA over DNA for the detection of specific rearrangements. Some of these gene fusions that are not seen at the DNA level can be very low, but very actionable. For instance, entrectinib. Now there are two FDA-approved drugs in the US, larotrectinib and entrectinib. And in clinical trials, there have been really complete responses of patients treated with these drugs when an NTRK fusion is detected. Some of these fusions can be highly prevalent in different cancer types like thyroid cancer and GIST, or secretory carcinoma of the salivary gland, or secretory breast carcinoma. We have done an in-house direct comparison between DNA and RNA, and we clearly show that RNA is the superior method for fusion analysis. And not only that, but the National Comprehensive Cancer Network guidelines do recommend RNA-based next-generation sequencing for patients with no identifiable drivable oncogenes to maximize detection of fusion events that are clearly actionable. So this is the Benayed paper that I mentioned earlier. They did a study where they analyzed 2,500 non-small cell lung cancer cases that were sequencing by DNA-based methods. And of those, 232 cases lacked an oncogenic driver. Now, when they sequenced these cases at the RNA level, they found out that 36 of them were having an oncogenic driver that was not found by DNA sequencing. And actually 33 of them were clinically actionable. And this is the table depicted here on the left. All these fusions are currently actionable. So this is our report. It's pretty straightforward. In the front page, you have all the information that you need. I mean, the report can be as extensive as 10 pages, depending on how many mutations the patient has. We have seen in the first case, there were at least 10, 12 mutations. That would increase, of course, the number of pages in our report. But it's pretty straightforward, with patient specimen information and the name of the physician and the location. We clearly identify, we find a biomarker or a gene with a drug association as a benefit in green. For instance, this case is a melanoma with a high TMB of 38 mutations per megabase with a drug association with pembrolizumab. Also a KIT mutation, drug association with imatinib. As you know, BRAF is very interesting in melanoma, but we also report lack of benefit when we don't detect any mutation. Why treating a melanoma patient with a BRAF inhibitor when you don't detect the mutation? We also have an important note here. Let's say we find a fusion. We're going to inform you about what the partner is, or if there is an NCI match trial or any other trial that might be relevant for the patient. We also include in the first page the cancer type relevant biomarkers. So for instance, the NRAS NF1 mutation, since this is a case of melanoma. So we, of course, we follow any FDA approval in the US, industry guidelines. I do personally extensive literature searches for molecular tumor boards or case reviews. and we appreciate every physician feedback. So we adapt our report to the physician's needs. So in terms of genomic signatures, I mean, I'm sure you're very familiar with, and this has been discussed earlier, but we also report microsatellite instability. I mean, in this case, I'm showing you here, de-identified was stable. The tumor mutational burden, now we know that the cutoff for a drug association is 10 mutations per megabase. So the result here clearly shows 12. So this would be a drug association with pembrolizumab. And we also report genomic loss of heterozygosity. And the threshold, we follow the threshold of 16% as per the Ariel 2 trial. So if the LOH is equal or beyond 16%, that could inform that there is an HRD defect or homologous recombination defect. So I've covered, the exome at the DNA level, the transcriptome at the RNA level, and the IHCs at the protein level. Now let's switch gears and talk about, our big differentiator here for Caris is the artificial intelligence, and I'm going to be talking about the GPS AI and the 4Fox AI. So we published last year in December this paper in this high-impact journal, Clinical Cancer Research, and this is something that we like to do at Caris, is to do a lot of internal research and collaborations to publish extensively, and is the clinical validation of a machine learning-derived signature predictive on outcomes from first-line oxaliplatin-based chemotherapy in advanced colorectal cancer. So what is this? So this is a 67 gene signature that we validated and then we apply and can predict whether metastatic colorectal cancer patients can benefit from first-line 4Fox treatment or FOLFIRI. So as you can see here in the table, when our 67 gene signature predicted that the patient would do better with 4Fox and bevacizumab, and actually the patients did get the right treatment or the prediction, then we see a 42-month overall survival. However, if we predicted 4Fox benefit, but the patients were treated with FOLFIRI, the overall survival was only 24.5 months. So you see clearly that the prediction and the right treatment increased by 70% the overall survival for metastatic colorectal cancer patients. I have to say that in the paper, and I'm happy to send this around. We also have the same prediction for pancreatic cancer for FOLFIRI, and also for GEG or gastroesophageal junction cancers. So the other artificial intelligence platform that I want to talk about is GPS AI, and it has nothing to do with your navigation system in your car, but it's rather a genomic prevalence score that does analyze a tumor's molecular signature and provides the prevalence of that signature in the Caris genomic DNA and RNA database across 21 cancer types. So what we do here, and I don't know how many COP cases you see in your practice, but this can definitely help you, or if you have an atypical clinical presentation. So you would send the tissue to Caris. We're going to do DNA and RNA analysis, and we're going to compare the genomic signatures with these 21 cancer types that are very well defined. And you're going to have just to tell you that we have published this earlier this year in Translational Oncology, and we definitely have the largest independent data set with more than 13,000 samples analyzed. And we call more than 93% of the cases with a very high accuracy. So in the report included in the MI profile, this is an example of the results of GPS AI. So that this was a CUP case, and the prediction determined that this case was a lung adenocarcinoma with a 97% likelihood. So this is a tool that can aid in the diagnosis. And we have seen in terms of clinical outcomes that more than 40% of cases in which there was a discrepancy between the primary diagnosis and GPS AI actually resulted in a change after further pathologist evaluation and diagnostic tests. So we have this information in the paper, and again, I'm happy to circle this paper around, but this is an example of a tissue that was sent to us. The diagnosis said squamous cell carcinoma. When we perform GPS, and by the way, GPS doesn't require more tissue and doesn't increase the turnaround time for the report to get back to you. And it turns out that our GPS AI predicted that this case was a urothelial carcinoma. So we analyzed a couple of markers at the expression level, and as you can see here, UPK2 and GATA3, which are actually markers of bladder cancer, were highly expressed in this case, which is depicted by the red line here. And those are the box plots of the expression of this gene across cancer types. So you can see here that this case actually fell under the urothelial carcinoma. So our pathologist confirmed the RNA expression data with IHC data, as you can see here with uroplakin-2 and GATA3. And we informed the medical oncologist and the pathologist that sent the tissue that this was a urothelial carcinoma, and they changed the diagnosis. Interestingly, now that the case is urothelial carcinoma, we performed a PD-L1 SP142 clone immunohistochemistry, and it was positive. So now that the patient has urothelial carcinoma, could potentially get atezolizumab. So every case profiled at Caris fits into our database, and given the amount of information and big data that we have, we turn this into AI signatures. So we are currently, I mentioned GPS AI and Fofox AI. I mean, we launched these products and the papers are out, but we're working on a pan-cancer brain metastasis predictor, a pancreatic gemcitabine Abraxane predictor, a non-small cell immuno-oncology predictor, ovarian PAR predictor, and ovarian platinum predictor. So since we don't sell our data, we actually make good use of all these data, and we collaborate with institutions to create all these predictors that can have clinical impact. So I believe this is my last slide. I talked about DNA, RNA, and IHC and artificial intelligence. Just to let you know that I've been told that by the end of August, we're going to be launching our liquid profiling. It's going to be unique in the market because it's going to tackle DNA and RNA analysis. We call that CNA for circulating nucleic acid, because we include the RNA component, and nobody else is offering this at this time. So I actually speak 4 languages, Catalan, Spanish, French, and English, and I would like to thank your attention in actually 4 languages. Moltes in Catalan, gracias in Spanish, pour votre in French, and attention in English. I leave you with my email here, and I'll be happy to answer any email or question that you may have right now. Thank you very much.
Thank you very much, Dr. Dusmir, for really nice presentation, and open the, surely we will have a nice discussion. Joseph, Wadia.
Yes, so hello everyone. I'm Wadia Mina. I'm the Access, Value and Policy Enabler for the Levant region at Roche. I'm also a pharmacist and a health economist. I'm a member of the board of the local eSport chapter in Lebanon, and I'm a part-time lecturer in the field of health economics at the Lebanese University. So Dr. Farhat, first, thank you for inviting me today for this webinar. And I believe the purpose of my participation was to kick off the discussion about the reimbursement of CGPs and on a broader perspective, the impact of precision medicine and oncology on the healthcare budget overall, and on how, and that would raise the question on how to assess the financial consequences and the value of adopting precision medicine and oncology. So I would leave the floor to the participants in case there is any relevant question.
Before that, we still have a presentation, no?
Not in my...
Yes, Dr. Aiji.
I believe on the schedule there is an additional
Dr.
presentation. Yeah.
Okay. Yes. Dr. Aiji.
I'm sorry for that, Faris. So we will move to the next, Dr. Ahmad Awada, if you can present Dr. Faris.
Yeah. Okay. Dr. Faris is, sorry for that, really.
That's okay. I thought you left me to the end, that's all.
No. So Dr. Faris Araji is Associate Professor at Qatar Biomedical Research Institute, and he will speak about how to optimize the collaboration in precision oncology between the countries, a regional consortium. And sorry once again for that.
It's okay. It's okay. Thank you for the introduction. So like I'm a senior scientist and at the QRI, Qatar Biomedical Research Institute. Thank you all for the attendees, and also thank you, Dr. Fadi, for the invite. Now, the question here is slightly complicated about how to do regional consortium. I will start by describing exactly what we're doing in Qatar, and that might be the pathway to a regional collaboration. Now, there was a lot of interesting talks and discussions, and especially the last one with the AI and also the previous cases. And I think definitions is a problem at the moment with precision oncology. So I don't think precision oncology is personalized medicine. They're not anonymous. Modern medicine, particularly oncology, has always been personalized. So personalized information for each patient on the TNM staging, tumor histology, a lot of biomarkers. It's routinely used to decide on the treatment for patients. So, when you look at the definition of precision medicine, the NIH defines it as an approach for disease treatment and prevention that takes into account variability in genes, environment, and lifestyle. So the multiple factors going in there. And then, unfortunately, and I've heard it in this talk, this has been hijacked by another field called genomic medicine, which is using genomic information in the treatment planning or the clinical care of patients. And that is really a problem. And this is good that the previous talk was talking about, and Dr. Fadi as well mentioned, that there are more information for different molecular levels. And genomic medicine is not synonymous to precision medicine, which is not synonymous with personalized medicine. And the reason, when you look at it from a biology point of view, my area of cell biology, it's actually, we come from one genome, and that gives us all the complexity moving forward. Let me just put the laser. We move from one single genome to highly specialized functions and organs. And this is going through a complex molecular interplay between many different things to actually go from the genome to cells with functions that go into tissue. Cancer is not different. It's the same. It's actually more complex because the genome is not very stable in cancer. So, when you look at this, I would prefer to change the definition if I was allowed and call it about molecular variability. That's what we really need to look at. It's integration of DNA, RNA, protein. One day we'll be looking at metabolome, hopefully sometime soon. So it's much more complex. And the question now becomes, why do we need precision oncology? If we agree with my definition. And one thing that's missing in the definition, and a lot of people don't touch on this point, it's a key word in the terminology, it's precision. So it's, for me, precision oncology is about getting precise about the treatment. And if you look at any standard survival curves from any cancer, and I'm talking about primary cancers, not metastatic stage, these survival curves, they show the average for a group of patients, let's say, any subtype that has the same clinical pathology treated in the same way. These graphs hide very important information. We have patients who survived or patients who didn't. So if you split this heterogeneity is hidden in that average graph. And even with patients that have an event like metastatic event, recurrence event, or death from the disease, the time that they benefit from the standard of care differs as well. So you have patients that respond for about 10 years and then they have a metastatic relapse or something, and patients who die within less than 3 years. So clearly there's a lot of different outcomes in the patients. And even when we look at a new drug that may improve survival by 20–30%, we are going from the red line to the green line here, but we still have heterogeneity. Not every patient who received that treatment is responding. And this is the problem. And really, we need to get more precise and accurate about predicting the benefits from treatments. Now, our enemy here are heterogeneities. And it's not one heterogeneity, there are many. So there are heterogeneity at the biological level, clinical level, and the personal level. At the biological level, we have the cellular and molecular heterogeneity, but of course, we cannot forget the tumor microenvironment. So we generally take bulk of the tumor, lyse it, collect DNA and RNA, and profile, but this is not how the tumor operates. There's immune cell infiltrates we cannot ignore, for example. And of course, sample quality and data quality is very important when we look at the profiles, but we have to remember that whenever we do profiling, we're looking at a snapshot from the biopsy or from the tumor, resected tumor. And this is not really how tumors work. They are very dynamic. They evolve very quickly. And we also cannot ignore the effect of treatments on the dynamics of the tumor because it changes it. Lastly, we have the personal heterogeneity. This lifestyle and maybe sometimes mental state could affect treatment outcomes. But the more obvious one is adherence to the treatment. For example, for breast cancer, we are assuming that the woman is taking tamoxifen pill daily or for up to 1 to 5 years. I mean, we don't know that for sure, really. So there are a lot of heterogeneity to deal with. And if we deal with this heterogeneity, I believe we can start approaching precision medicine. Now, the issue is, how do we do that? And this is where we need the model to figure out how to do precision oncology, and on a larger scale. I mean, case by case, it's very important, but for healthcare system, there's something bigger, and this requires paradigm shifts. We need to move away from, move into dynamic integration of diagnostics, therapeutics, and include biomedical informatics, which includes bioinformatics and medical informatics. And this is where AI might help a lot, because the amount of data is insane from coming out of all of this. We need to also move from average efficacy of treatment to the individual benefit. How does this patient benefit? So become more patient-centric. And as I mentioned once previously in one of my comments, that we need to move from ad hoc treatments when we see at the time of progression to actually do all this profiling at the time of first diagnosis and understand the tumor. And sometimes we do have to repeat the profiling, unfortunately, because the tumor is dynamic, like I said. Now, this is not easy, and it requires investment and funding. But I really believe that with time, this will allow more saving, because you have less re-hospitalization, less retreatments, and more alleviation of the burden of disease. Now, for my part as the research side, I really try to cover this area, going from diagnostics to therapeutics. We stay closely to the clinical side with clinical samples. That's where the research is happening, is starting, and we hope to move things towards clinical practice. So we always deal with the clinical collaborators closely, because that's where we will try to keep it. Now, I don't want to talk about my research, but just to mention that I have recently moved to Qatar. It's actually not recent. It feels recent. I moved just 2 months before the COVID pandemic, so I've been in lockdown for about 15 months. So I'm really just now starting to gear up into work. Now, I'm building the Translational Cancer Research Group. And I moved from a Western biomedical research system from Australia. And coming to the region, one of the first questions I had was, we need to identify areas of unmet needs locally, because there's a lot of innovations, a lot of profiling happening for overseas tumors, Caucasian mainly, but ethnicities might play a role here. So we're missing this. And the other building block that I'm working on is building collaborations and networks. Now, by doing this, we can tailor research. And I'll just very briefly describe here the sort of programs we're running. So we have a first program that is it's called the IDRP, so Interdisciplinary Research Program. This is for our entire center, so all the research groups in the center collaborate and work on this. And we're collecting prospectively breast cancer samples from the Hamad Medical Corporation, so that's the main hospital health provider, national health provider in Qatar, and also in collaboration with King Hussein Cancer Center in Jordan. So this is actually trying to look at multi-omics. We'll be looking at multi-omics, DNA, RNA, protein, blood, tumor, and looking at genomics, transcriptomics, and proteomics, and metabolomics as well. And this is to go into really characterize regionally what kind of cancers we see. So we will have Qatari and Arab populations here. Now, my lab will also be leading this kind of work of doing the same analysis with the Cancer Genome Atlas data and trying to do comparative omics to actually find what's similar and different in Arab tumors and others. Now, this will allow us to also tailor our preclinical research to the region as well, based on biomarkers and based on experiences we see here and based on profiles we see here. This is also including generating our cancer cell lines, breast cancer cell lines from the region here. Now, for my talk today, I'll be talking about the first and last point. And the first one, I'll be very brief about it, because the second point, I think it's more relevant to this talk. But the other thing we've started on building now is the Qatar Precision Oncology Diagnostics Project. And this is actually digging back and leveraging archival tissue for retrospective profiling to carry out targeted panel profiling, DNA, RNA, and protein. And I'll explain that in more details. Coming again to the region, my first question was, we need to figure out priorities. And this is, I'll go very briefly with this because that's not really the point, but there's a message from this. The first thing to do was to actually look at, cancer incidence in the Arab region. So I've analyzed using the global cancer data for 2018, looked at the incidence of cancers in the region for females and males, for all groups, for age-specific groups. And in females, we found that 5 particular cancers have higher age standardized rate than the global rate. These are breast, liver, bladder, Hodgkin and non-Hodgkin lymphomas. For males, it was the same for cancer, of course, not breast cancer, have higher incidence rate than global rate. Now, one thing that got my attention is that mortality to incidence ratio, which is not a surrogate for survival, but at least gives us some indication about mortality to compare across regions. Compared to the global MIR, we have a lot of examples of cancers that have higher MIR for the Arabs than the global MIR. This suggests a scope for improving treatments. And when we look at age-specific trends, high liver cancer incidence in both sexes over 30 in the Arab region are really driven by Mauritania and Egypt. And this is in fact preventable. This is mainly due to cirrhosis, due to prevalent hepatitis C infections that are not treated very well in these areas. Another point of interest was cervical cancer. And you can see that it happens at all ages, but particularly it's Northern African countries have high incidence of these cancer. And again, this is preventable through vaccination to fight the prevalent HPV infections in these areas. Now, thyroid cancer was another interesting cancer. It has high incidence in many Arabian Gulf countries and the Levant in females. And this is suspicious because this could be linked to some genetic syndrome, and we don't know this. We don't have information on this. The next cancer, childhood cancer, so for children under 15, there seems to be high incidence, higher than the worldwide ASR in young girls and boys. And for NHL, for example, this could be linked to hepatitis C, but we don't have evidence for this. But again, the high incidence in these blood cancers make you suspect some genetic cause. Finally, for breast and ovarian cancer, it seems to be affecting younger women, particularly in the Levant, Lebanon, Syria particularly, and then followed by the Northern African countries. And you can see some sort of increase of ovarian cancer. So this is suspicious of hereditary breast and ovarian cancer syndrome, Hitchcock syndrome. And if you look at BRCA1 and 2 studies in Arabs, they exist, but it's not comprehensive enough. And looking at pancreatic cancer, it also seems to affect younger females and males. Again, it's the Levant and the Northern African countries. So this again could be related to Hitchcock, but it also might suggest that there's more BRCA2 mutations than BRCA1. And also there could be a lot of mutations in other DNA repair genes. Now, just to summarize this part, the Arab region does seem to have different cancer trends than other places. There may be a lot of genetic factors, and this could be a lot of marriages of close relatives. But to come back to the point of this event, so apart from tailoring screening and prevention strategies, treatment might be needed. For example, if we know that BRCA1, BRCA2, or DNA repair genes are highly mutated in the particular cancers we see, then we might need to start looking at using cisplatin and maybe with PARP inhibitors as a first-line therapy rather than doing second-line therapy. So that information is very important. And this brings me to the second part, which is more relevant, is the Qatar Precision Oncology Diagnostics Program, QPODEX. And in here, we're not taking a whole genome approach yet. So we're planning to do that prospectively study. But in this retrospective, we want to dig back into the FFPE archival tissue. And we want to target certain panels that we know that have clinical actionable information that MDT might find useful. This includes TMB and MSI, which were mentioned before, cancer mutations and cancer driver genes. We want to look at molecular subtyping of cancers, look at spatial profiling by multiplex IHC, and of course, looking at predictive signatures. So it's sort of similar to what the previous presenter from CARIS was talking about. The point of this is to actually figure out, from the cancers we see locally, are there different trends? Are there different molecular profiles? And eventually, what we hope to do is include this in part of molecular pathology. So a biopsy is actually profiled with 3-dimensional, 4-dimension, whatever dimensions we can get, to get the most amount of information that would help the MDT to make a decision for that patient. So in case, if you can predict that standard therapy will work, for example, chemotherapy, radiotherapy, that's great. In case we predict it's not going to work, this is when we start thinking that we need to start thinking of other therapies as targeted therapy and immunotherapy, for example. Now, tumor mutational burden, this was mentioned before, and I'm not going to spend too much time on this. The major point I want to say from here are 2 points. The first one is this landscape is based on Caucasian tumors. we have no idea how the Arab tumors look like, because who knows, we may have high TMB burden for a lot of cancers. So we know that all the cancers sit in this region. We don't know the landscape in the Arab region, Qatar or the MENA region. And also TMB is not the only marker for immunotherapy. PD-L1 expression, tumor infiltrates, there are other markers for immunotherapy benefit. The missing data here is that we don't have cross-sectional data on TMB, TILs, molecular profiling on a large scale for the population to understand what really should work for us and what areas should be filling in terms of diagnostics links to therapeutics. This is another example looking at the mutational patterns for breast cancer and the molecular subtypes for breast cancer. And I mentioned this before that PIK3CA mutations have been recently got FDA approval for treating refractory ER-positive breast cancer. We don't know how many of the breast cancers in the MENA region have PI3K mutation. And from a health point perspective, to start making the case that we should invest into this, we need that kind of information. And again, similar thing with the molecular subtyping, the PAM50 subtypes. And apart from them being prognostic, there's a test based on the PAM50 subtypes, the Prosigna, which works similar to the Oncology DX, and it avoids chemotherapy for patients that have low score. Now, I don't know if this is the same in other countries, but the breast cancer MDT in Qatar sends some samples to the US to do Oncology DX. That's a $5,000 test. We can do something similar here. But the message from all of this is that the mutational and molecular landscapes of cancers in Qatar and the MENA region are unclear. So the vision here is that cancer omics have provided a lot of information about heterogeneities and how to deal with them from a clinical perspective, not just research. But all of that information is based on Caucasians, which may be very well different from the cancers we see in Qatar and the MENA region. And our strategy was to form this alliance between the different stakeholders, including, like what I mentioned, Hamad Medical Corporation. This is the National Cancer Care and Research Center that treats most of the cancers, maybe all of the cancers in Qatar, and 2 research institutes. And what we want to do is to test and evaluate clinically relevant molecular profiling of cancer tissue in Qatar. Our study is in 2 phases. The phase 1 is a retrospective study. So like I mentioned, we will start with 6 cancer types. And we plan to do 2 things. First is next-gen sequencing to look at tumor mutational burden, MSI, and cancer driver mutations. And we actually now deciding to include more panels. I'll come to that in the next slide. And we also want to look at the microenvironment profiling. This includes 2 things. First, the multiplex IHC. We're using the Mantra system, where we can move to more clinically relevant platforms. And we'll also be looking at bulk profiling for cancer markers, cancer pathway, and immune pathways. So the information from this is to actually look at the immune pathways and signatures and immune infiltrates alongside with predictive and molecular subtyping at the mRNA and protein, and link all of this for the same case with the mutational and genomic information. Strategically, we are leveraging a lot of resources invested in Qatar, and Qatar has done great in investing in the infrastructure to run all of this kind of things, to test molecular diagnostics and see which ones are meaningful and which ones that inform more policy making and more actually clinical practice. The other part is translational outcomes from the retrospective study, because we have the survival information already. We can associate the molecular landscapes we see with patient survival and start finding the patients who did not respond to the standard of care or whatever treatment was given to them, why did not respond, and could we have predicted a different treatment, such as immunotherapy or targeted therapies. Now, the clinical outcome is to start, we want to generate data that support the clinical and business case, to start including some of these tests and routine practice. It might be too expensive to run it for every patient, but I would argue that we should run it to every patient from the beginning. And I think I mentioned this point before. After our retrospective phase, we want to look at starting to work prospectively. I mean, we can expand to include other cancers and hopefully cancers from other Arab countries eventually. But one of the main issues, and this was touched on with the case reports before, especially when you start running this in a hospital system on a routine basis, is the pathway for running and reporting the tests timely to the MDT, and also not swamp the MDT with information and they're lost about what to do. Sometimes even AI, I would say, could get lost in what we should be doing. Now, this is a big project, and to actually get it working, we have a big team involved, and we're still working on the team structure and team memberships. But it's organized in the way that we have a steering committee, cancer-specific teams, and we have support teams, and of course the funding. The steering committee team is led by Dr. Mohammed Salim. He's the medical director of the NCCR in Qatar, and we were lucky with his great support and vision. And he bought into this concept straight away from the first presentation, because it really sits with the agenda and the vision for the NCCR. It's called Mustashfa Al-Amal Bil Arabi. The way we organize it is that each team is led by the clinical lead that formulates different groups. So we're almost done. We just need to finalize these two groups with the team members. So the teams would include subspecialties who are experts in the area of the cancer we are really looking at. Now, from the funding part and the support, so Qatar Foundation, which is my employer, have started the Qatar Precision Medicine Institute. This is a new entity with a new vision, which is to move precision oncology from research to practice. And it's going to be an enabler for this kind of development. So we have presented this proposal to them, and Dave Brown, the Science and Programs Director, he comes from Genomics England, and he's moved to Qatar to lead, and he's almost the architect of QPMI operations, like what to do. They bought into this project, so luckily we're going to get the funding for this. And it was also offering to do whole exome sequencing, because we might discover genomic mutations that have high prevalence here that could be actionable, but they're not usually seen in other places. And the other part is to include Foundation 1 panel, because the QPMI has multiple agreements and MOUs with industry partners, including Roche and Illumina. So we are looking at including the Foundation 1 panel in parallel to the Illumina one. So, sorry, just a second. Now, I'm not sure how I'm looking for time. I might skip these, just basically what we're expecting. So what we're really expecting is to start looking at molecular subtyping of cancers in a clinically relevant way. For example, for colorectal cancer, we know that molecular subtypes have different mutational and immunogenic profiles, and they would respond differently to different treatments. And it's important to know how do we have similar percentages of colorectal cancer subclassification in Qatar and Arabs or not? And immunoscore is another thing we're looking at testing. Same thing with bladder cancer, molecular subtypes differentiate treatments, and this actually provides benefit from immunotherapy. So again, we're really trying to draw the same picture that's drawn for Caucasian cancers. We want to draw it for the Arab region, and this information is missing. And same thing with endometrial cancer, molecular subtyping that has different outcomes, and we can look at eligibility for immunotherapy based on TMB, PD-L1 expression, but also another profiling of mutations and also predictive markers. And last, cancer. Sorry, I'm skipping through this. It's just we've probably covered a lot of these topics already. Thyroid cancer, for example, is prevalent in Gulf countries, including Qatar, in females. And I think most thyroid cancers are easily treated, which is the case. But you get some types of papillary thyroid cancers and also other types of thyroid cancer undifferentiated. They don't respond very well. And recently, it's been shown that there's a subset of thyroid cancer that has high TMB, it expresses PD-L1, and has BRAF mutations. So these may be candidates for immunotherapy, which is unusual for thyroid cancer, but it could be that the thing that we have to do. Now, to answer the questions about how do you move to this information to the clinical tumor board setting, molecular board setting, this is covered, has been covered. It's just that you need to see a report with actionable molecular data backed by clinical evidence, easy to interpret. I would say, prognosis for standard of care should be provided, because if the prognosis of standard of care is going to be not very good, we need to provide prediction of alternative, more precision oncology kind of treatments that, based on the molecular profile, we predict it should be the treatment, and suggest an optimal treatment in a clear way that doesn't confuse the clinician. Unfortunately, we cannot always promise that, because I work a lot with whole genome and whole transcriptome profiling. Sometimes I get lost and I think I know a lot of things. It's not easy. This is where AI is needed. Now, if this is our target, the path to this, we need to integrate molecular pathology into routine pathology. And this might be costly, but I think it will have cost effectiveness and reduction in the future. And maybe with the panels we can discuss this. And we also need the framework for timely and meaningful data reporting. And these two center stones of doing precision oncology has a lot of background behind it. We need to keep our interdisciplinary collaboration in the clinic, pathology, at the research side. And this has to be very dynamic, and we need to always continue learning and education because information comes out about drugs, mutations, new tests, and so on. And I would say, importantly, we need the dynamic clinical research environment because we need to keep evaluating the relevance of new information, new diagnostics that come out, particularly, I would argue, for our own patient population in the Arab region, because we are absolutely underrepresented in any international omics study. We also need to generate local evidence and experience to demonstrate capacity to enable and data to enable cost-effective cost-benefit analysis for the patients and the healthcare and how we deal with the increased costs. Theoretically, precision medicine message is to say, you might pay more for more tests to be done at the beginning, but that will save you money later for the life of the patient, of course. But then the associated cost of pre-hospitalization, retreatment, and all the other associated healthcare costs. And lastly, last but not the least, we need to start looking at innovation related to our own populations. We might find that some mutations are more prevalent in a cancer type that does not have an indication to be treated with X drug. It could be an off-label use. We need to start thinking this way. I'm not sure if we can run clinical trials in the near future, but we should be. Our population looks very different. So this is my reference list if you want to have a look at it. And thank you for your attendance. And just to say, the last thing is, to answer the question, how can we have a regional collaboration? I don't have an answer. And my answer would be, this is an example in Qatar. We might tag on it. We might collaborate on it. But I do believe that we need collaboration. We are the size of the US, and we need to start, with 300, 400 million Arabs, and we need to be studied from the cancer point of view, and we need to tailor our diagnostics and treatments to our population, which I really think from the incidence data looks different. Thank you very much.
Thanks a lot, Dr. Faris, for this really very clear and mainly exciting project. Basically, if I could summarize it, you are looking for molecular epidemiology, basically in relation to one country, which is Qatar, and also in the region, Arab region, and that's really very nice and exciting project. I think we heard three important presentations from Dr. Fadi about tumor profiling, the importance of clinical practice, artificial intelligence, and precision oncology, and the last from Dr. Faris, and now is open for discussion. I am sure that Dr. Sami Khatib is very sensitive to project in the Arab world, in the Arab country. Probably we will have one comment, Dr. Sami.
Really, it is amazing project, and I think they are willing to have the collaboration with all of us, inter-Arab collaboration. We are welcoming this idea, and with Dr. Farhat 2 or 3 weeks ago, we were talking about this. So Dr. Faris, thank you for this presentation, and we are really happy to have a contact with you and to start some kind of collaboration between the other centers that you are collaborating with now in your projects.
Dr. Faris, I agree with you that really creating a network of clinical research in order to translate all this new development in your project into, let's say, clinical practice is really of utmost importance. And I am sure that it's a challenge, but I know that there are many, let's say, initiatives in several countries, and it's important to put it together. Fadi, probably you will comment on that because you are leading also, with other colleagues in Lebanon, for example, some important clinical research activity.
Yes. Thank you very much for all participants, for all speakers. Indeed, one of the aims of this ABC educational course is to create a kind of network, because I think, as it was said by Dr. Faris, we have the same size of maybe USA, but not really far from the same efficiency. And I believe that with the small steps, we might start. We at our level had a local cancer research group, and then after we create an Africa Middle East cancer intergroup, but we are lacking resources somehow really, and support of the pharma, and we are lacking some perseverance in the work, because as you know, in this region, it's mainly a private practice. So joining the private practice with the research is not easy. Nevertheless, we are trying. So one of our goals is really to try to collaborate. And here I asked Dr. Faris after this meeting to have a one-to-one meeting to try to elaborate more projects with the AMAC, Arab Medical Association Against Cancer. So that's what I have to say. And if you allow me, Dr. Ahmad, I would like to ask Dr. Mina, because really knowing that in the region we have different level of economy. We have a high level like the Gulf, we have a intermediate and low one. So it might not be the same interpretation of this analysis. It's not done everywhere. So Dr. Mina, what's your opinion concerning the cost analysis? Do you find that precision medicine in general is cost effective? Dr. Faris and other speakers said it might we might economize, but I'm not sure if you do it for all people from the beginning, we'll do economy, and I'm not sure if we'll do it later when the patient is in palliative care stage, it's also okay. So really, what do we have to do? What's your opinion, Dr. Mina?
Thank you first, Dr. Fadi, and thank you, Dr. Faris, for the presentation. It's actually a very tricky question, and one of the great promises of precision medicine was actually to reduce the cost of treating cancer. However, with the increasing use of precision medicine and oncology, we've realized that we actually have been aspiring for the wrong objective. And to put it in a very simply and laid way, if basically the precision medicine and oncology provides better outcomes for patients, basically patients will live longer and will need longer periods of treatment. And now what I'm talking about is only financial consequences and not outcomes. Accordingly, looking at cost minimization when introducing precision medicine would be the wrong, let's say, aspiration. It wouldn't always generate cost containment or cost savings. However, what we should aspire for is to look at what are the outcomes generated at patient level. So in other countries where they have decided on how to judge on that, they would look at how many QALYs, for example, a patient would gain from following a different pathway, for example, CGP and comprehensive genomic profiling and the subsequent suggested treatment instead of the standard approach. So overall, if we want to resume that topic, it's very hard and it's a big challenge for health economists currently to draw conclusions about precision medicine. It's definitely not possible at this stage to draw generic conclusions. We try to fragment the topic and look at the different diseases in a, if I can say, in a narrow perspective. So, so we would look at what are the possible treatment options, what are the outcomes, and try to model results accordingly. It's definitely a very dynamic field, and no conclusion can persist over time. It will be very dependent on the new molecules discovered, on the new data gathered, and all of that. So That's it. In general, there's plenty of information that could be discussed further.
Thank you.
Fadi,
No, I'm just saying thank you for Dr. Mina.
okay. I had a question to go back to the presentation of Dr. Desemir. I missed something in your presentation. I'm sorry for that. What is, you are mentioning artificial intelligence, and you in your new, let's say, technology looking to predict the efficacy to chemotherapy in colon cancer, let's say, to define, to document the type of the tumor with the other. How artificial intelligence intervene here in order to arrive to your new technology?
Well, at Caris, we believe that artificial intelligence is definitely the future. To use the amount of information that next generation sequencing is providing at the DNA and RNA, and we are seeing that by combining that information into algorithms, we can clearly define certain signatures that can predict whether patients are going to benefit from certain treatments. I mean, it's pretty clear from our publication from the FOLFOX AI that, if the prediction really tells you that the patient should be getting FOLFOX, I mean, the patient should begin FOLFOX and stay on FOLFOX. But if the prediction is inversely correlated, I mean, and I failed to mention that in the presentation, but actually I know for a fact 2 physicians one in Hawaii and one in California, that upon getting our results of decreased benefit to FOLFOX, they actually changed the patient to pembrolizumab, for instance. So this is, a really a clinically driven management of patients by molecular artificial intelligence. For the COP cases, we have 200 DNA features and 250 RNA features. And, we have a whole team dedicated to that, at finding, what are the right combinations of, expression, point mutations, combinable aberrations that can help in the diagnosis of a case. And, like I mentioned, the case on squamous cell carcinoma, I mean, the patient got standard chemotherapy, did not respond, but then we come in and then we say, well, we believe that this case is in fact urothelial carcinoma. And now the patient has another chance, which is being treated as urothelial carcinoma patient, potentially with immunotherapy, given the PD-L1 staining clone SP142. So that's why we invest a lot of time and money actually to develop these AI platforms, because we believe that can really help in the management of cancer patients.
Okay, thank you. I don't know if there are any questions or comments from my colleague. Probably I have one question to you also, Dr. Desemir, that I think what could be of interest, your approach, your strategy. Of course, in the palliative care, in the palliative setting, in metastatic setting, so there are something really important. But what could be more important is in the adjuvant, neoadjuvant setting, if we could de-escalate or escalate our therapy to patient. Do we have some project in this setting? I mean, early setting rather than metastatic setting, because metastatic setting, we are a little bit too late.
Yes, and it was part of the slide on the GPS, although I didn't cover it in the interest of time, but we see also that it can help in the primary tumor setting, not only in the metastatic setting, to try to identify what this case is, what the tumor type is. To really answer your question about the adjuvant, neoadjuvant setting, yes, we're working on this, and this is something that Caris is interested in.
Yeah, because there are strategy escalation, de-escalation there.
Absolutely.
Okay. Any question, comment?
I just have a comment about the AI use. I mean, when you start generating all this data, especially if sequencing gets low in prices, and we do panel profiling because it's more cost effective in a sense. When you start doing whole genome, whole transcriptome, you need AI, and especially if you add on top of it the tumor microenvironment spatially. How does the tumor look? Where do the immune cells sit? Because that makes a difference for therapy response, both neoadjuvant chemotherapy and also immunotherapy. There is no brain that can handle that information. You need an AI, and there's a lot of relationships that you cannot pick Doesn't matter how much you read and how smart you are. You cannot pick those relationships. You need an AI to pick them for you. But I'll only say for the AI is that we also need to learn, because a lot of AIs, we need to tell it what to look for sometimes, especially if we give it a very heterogeneous. So we really need experts also, clinicians included, to feed the AI with information that's of relevance. Maybe in the future, in a few years, AI will become completely independent from our input, hopefully. So yeah, we'll see. So, but there's just a comment about the AI use to you, Dr. Ahmed. We do need it when we get more complex and more broad information to pin it down to a particular point and avoid mistakes, because mistakes do happen. You can avoid them, and that could reduce the cost both on the patient life and the health system as well.
Okay, thank you, Dr. Farid, for this comment. Yeah.
Yeah, just a quick comment. I mean, it's pretty clear to us actually that we need to move beyond a finite number of genes in a cancer path. The more information, the merrier. The problem is how to interpret it. But how to interpret it is, when you have a whole team of PhDs like myself and at Caris, in 1 year, we went from 7 MSLs to 40 MSLs, which clearly speaks to the strong scientific support that, we're facilitating to help physicians understand the huge amount of data that NGS and AI platforms are showing in the report. So it's not just having a lot of information, but again, it's how to interpret it. And having a whole team of PhDs behind for one-on-one case reviews or molecular tumor boards. I mean, we facilitate educational sessions for MDs that are not extremely savvy in pathway analysis or genes or specific mutations. Also, another comment, and I agree with Dr. Fares, is and I've seen that in the US in the community setting. More and more, I talk to physicians and they tell me, yeah, I would like to start profiling right away, upon biopsy and diagnosis. Sorry, Fadi, I speak 4 languages, but not Arabic, so I didn't quite get what you said. But,
sorry, we lost electricity, so I'm calling. I'm sorry.
Okay, no worries. So yeah, going back to my comment, actually, interestingly, Caris is sponsoring a trial in the community setting in a hospital in California, where the physician is clearly interested in profiling right away in several community hospitals to try to see, the impact that this has in hopefully in the short term, or especially in the long term, in terms of outcomes for the patient. I mean, the case that was discussed today for the lung, I mean, this is a clear example that, having profiled earlier, which potentially have, expanded the overall survival, or maybe, I don't know, I'm just hypothesizing here, but maybe saving the life of the patient here.
Okay, thank you. Yeah,
so Doctor, I have a question, Dr. Prabhat.
Yeah.
So you think the GPS AI may also be useful in cases of tumors of unknown origins?
Yes, this is exactly what the GPS is for. It's for cancer of unknown primaries.
Okay.
And also we have seen that it can help also with the, and this is in a conversation with pathologists that they tell us. Thank you. We started a conversation with the pathologist team that sends us the tissue, and with the medical oncologist, because sometimes the pathologists don't know what it is. They do an in-house panel of IHCs, and then here we come in and we can help them to define what is this atypical presentation. Sometimes they don't know what it is, and I come from the melanoma field, and I know that you put 3 pathologists looking at a slide, 2 are going to say that it's a melanoma, the other one is going to say that it's benign. Well, if we can use AI to really define whether it's a benign or a primary tumor or a MET, I think it's very relevant.
Okay, thank you. I think we are at the end of this webinar.
Dr. Ahmed, we have one question and one comment. If you would like me to read it from anonymous from the attendees, Why use everolimus in Richter amplification? Everolimus does not affect mTOR-C2.
Yes, I think it's a question for me.
Yeah.
Indeed, we use the everolimus because it inhibits the mTOR. It's an mTOR inhibitor, so it's impact the PI3K mTOR ACT pathway. And the Richter here has nothing to do with. The Richter is simply an amplification that make the disease more aggressive. It's showing aggressiveness of the disease. So we had nothing at this time. We had no PI3K inhibitors. That's why we used everolimus. And it's blocked the pathway. That's the idea.
Okay, the second one is from our friend, Dr. Kakil Rasul. I am lead of GICA in Qatar. I am using immunotherapy in a cohort of patients with colorectal cancer, 15 patients in different setting metastatic, neoadjuvant and adjuvant. We have very good outcome. Is there any data from the region on immunotherapy colorectal cancer?
Who would like to answer?
Clinicians, I hope.
So I will start. Indeed, we have some anecdotal cases, rare cases of colorectal cancer with high MSI treated with immunotherapy. Even before the approval, we used nivolumab at this time before the approval of Pembro in all kind of tumor MSI high. Yes, but it's rare cases. Now, I will ask you back, Dr. Kakil, do you use the neoadjuvant and adjuvant? It's somehow, I think, not indicated, but you can do it. But theoretically, it's indicated in MSI high metastatic setting.
To my knowledge, there are one study reported 2-3 years ago in neoadjuvant setting. I think it was nivo-ipi, the combination, and showed very, let's say, good PCR rate in this trial. We can check that.
But since it's an educational course, we
yeah,
have
it's important
to,
not to, yeah.
Yes, we have to limit ourselves to what's approved by guidelines. So it's not guidelines approved, but
Correct.
we might use it in occasional cases.
Okay, Fadi, I think we are depressed a little bit. The time now is
we are
25
done.
Is done. I would like from my side thank really all the speaker and my colleague from the panel discussion for this nice presentation. Personally, I learned a lot. What I, probably Fadi for the next course to have one session about how to build, let's say, network of clinical research in the era of molecular oncology, because this is really already creating network is challenging, but in the precision medicine era is much more challenging. I can tell you one example from our site here in Belgium, in my institution, in my network, that's really is difficult to open 100 of clinical trials to put 1 or 2 patients in each clinical trial. So it's important to change the model completely, and that could be a matter of for discussion in another course. So back to you, Fadi, and to Dr. Sami for the last word.
So just before giving the floor to Dr. Fadi for closing remarks, just I would like to announce that our next activity will be next Tuesday, August 3rd, about hematological malignancies part 2. Dr. Fadi, the floor is yours.
I received a lot of comment about the session, and some of them told me that it was the best one. They enjoyed a lot. So indeed, it was really excellent. I really would like to thank every and each one of you for his input. It was really excellent. First. Second, I will do as per Dr. Awada advice, and I will try to communicate. It's not easy, guys, because to arrive to Dr. Faris, I went through 2 people before knowing him. So we'll try to create this network, and I think Dr. Faris will be one of the leader in such way. Third, I would like to ask you to support Dr. Ahmad Awada for the ESMO.
I think
لا it's true. أحمد عواضة يعني بنعيط له أحمد عواضة without staying a professor or doctor because he's really close to us. He's really close and his input was really great in our region. So we owe him this report, and for sure we will work with that, Dr. Ahmad. Finally, I would like to thank you again. Thank you very much for all participants. It was an excellent session. Thank you very much, and we'll see you soon.
thanks.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye.
Bye-bye.
Bye.
When facing cancer, how can patients know they're armed with everything they need to guide their treatment? Foundation Medicine has developed a comprehensive and validated approach to identify clinically relevant genomic alterations in a patient's cancer, providing doctors an opportunity to personalize treatment options, including targeted therapies that may be more effective and less toxic than traditional chemotherapy. Our approach begins by looking at genes, oftentimes hundreds, that are known to be associated with cancer, using a tool called next-generation sequencing, or NGS, to help find alterations in the patient's DNA that are causing the cancer to grow. Alterations can happen anywhere in the gene, and there are 4 major types. The building blocks of our DNA may be substituted, inserted, deleted, duplicated, misplaced, swapped, or just plain broken. In all of these cases, the cells may end up working differently, causing a tumor to grow. Other tests, such as multi-gene hotspot NGS tests, only look for 1 or 2 types of alterations in predefined parts of cancer genes. Hotspot tests, therefore, may identify common alterations, while overlooking unanticipated but potentially important and actionable ones. By contrast, Foundation Medicine's comprehensive genomic profiling approach broadly analyzes the tumor genome to identify clinically relevant alterations and potentially expands your patient's treatment options. We offer a portfolio of comprehensive genomic profiling services for patients with solid tumors, hematologic malignancies, and sarcomas, including a liquid biopsy service for patients with solid tumors. Our approach analyzes cancer-relevant genes to detect the 4 major classes of alterations specific to an individual's cancer. Some of our services also measure specific genomic signatures, such as tumor mutational burden and microsatellite instability, which can help inform the use of immunotherapies. To find these alterations, Foundation Medicine uses advanced algorithms developed by some of the world's foremost cancer genomics experts and computational biologists. Our approach combines this expertise with our database of cancer genomic insights, one of the world's largest, to continually optimize and improve our algorithms, allowing us to efficiently and accurately discover the unique alterations and genomic signatures in a patient's tumor. We then issue a clear, in-depth report with insights on the patient's genomic profile, as well as associated targeted therapies, immunotherapies, and relevant clinical trials. The end result? Doctors have what they need to make a more fully informed decision, and patients have the assurance that no stone is left unturned in their treatment.